Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. Historically, the best way to reach your heart has been through your chest. I know there's something more a romantic way to say that. The best way to get to a man or woman's heart is through their chest. Surgeons used to make a long incision, crack open the rib cage. Sometimes they have to stop your heart beating, even freeze your heart to get their work done on your heart, whether it's a heart valve or an artery, etc. But over the past 2 decades or so, less invasive options have revolutionized heart surgery while leaving the chest bone, or the sternum, intact. Today we're going to explore those less invasive heart procedures, specifically for repairing or replacing heart valves, a surgery that when I was younger, patients were off in the hospital for a week or two after and with a lot of complications. But now it's amazing what the physicians can do with their whole team by running a wire and catheter up through the blood vessels. We'll meet someone who had a heart valve replaced and barely spent a day in the hospital afterwards, after replacing the valve of their heart. We'll ask how doctors decide what artificial valve to use, because there are a lot of options. And we'll find out when we still have to prefer open heart surgery. Later on, we're going to check in with Doc Hawk for a summer update on COVID and bird flu. Hint, it's his fault. COVID's on the rise again. Darn it. Joining me today is Dr. Peter Tadros, an interventional cardiologist and division or section chief, I think, of interventional and structural heart services here at the University of Kansas Health System. Dr. Tadros, glad to have you.
Glad to be here.
I've known this guy for approximately a very long time, so if I make fun of him today, don't be surprised. We're also hearing from one of his outstanding patients, Jake Seltzer. Now, Jake is a Jack Seltzer, our most loyal viewers may remember Jack from a prior episode. He's been on the program before, and since then, he got a new heart valve. We're glad you're back, and we're glad that that new valve is working, and I will call you by the correct name today, I promise.
That's fine.
Catheter-based heart procedure started as a plan B for patients who weren't eligible for surgery. That is, they were too sick or they had a complication and they couldn't even have the surgery. But today, it's become the standard of care. Dr. Tadros, help us trace the progress. How far has this heart valve thing come?
Extremely far. So, and we've been fortunate at KU. We were involved with some of the early research about 15 years ago. So we've really seen the evolution. But as you said, it really was a plan B. It was something that initially was felt to be impossible to do, especially in the aortic valve. And then it became a prototype, and then it became a bailout procedure. And now, really, in randomized trials comparing to surgery, it's actually emerged to be at least equal and maybe a little bit better than open heart surgery. So now it's become really a default treatment for many patients at KU and around the country. 80% of aortic valves, at least 80%, are being done with these minimally invasive transcatheter processes.
That is crazy, and I know we're going to show a video in a moment, but more often than not, this has been a problem in older and elderly patients that have heart valve work. What ages is that usually be?
Well, so really it's kind of 65 and older is really the cutoff that we currently use. There's obviously exceptions, and it's a spectrum. But as we get older, we're more prone to developing aortic disease, which is basically a calcification of the aortic valve leaflet, so it doesn't open as well, and the heart becomes stressed, and we have symptoms. And if not treated appropriately, I mean, the mortality is actually very high for severe aortic stenosis.
So I'm glad to hear it's 65 and older. That means they got a few more days before I have to worry about that, but a little closer. All right, now we have video that we promised from one of the procedures inside the cath lab. Walk us through what we're seeing.
Yeah, and this is not a aortic valve. This is a different valve, the pulmonic valve. This is often in patients with congenital heart disease have really leaky valves. So this is a valve replacement of the pulmonic, and you'll see me on the left and Dr. Tripp Zorn, one of our cardiac surgeons. These procedures are often done with an interventional cardiologist and a cardiac surgeon. What you're seeing us now is we're using ultrasound to access the major vessels in the leg to make sure we're in the right spot to thread our wires, and then we use that as a gateway and a highway to get up to the heart. So instead of going through the chest as you alluded, we can actually go through the femoral arteries or veins in the leg, right in the groin area, and then able to put large sheaths or tubes into those vessels, and then again allow us to put our devices up to the heart. You'll see there's wires there, and the wires actually are put in the place that we want them to be. We do that manually, and then over those wires we put the valves that we need to do.
Okay, that thing looks big to me, but it goes inside the heart pretty well. Huh?
It does, and that's actually the very slenderized. So that is, it looks almost like the diameter of a pencil, and then as we get it into the position, we actually unsheath it or take away a sheath, and as we unsheath it, the valve starts opening up.
What do you do with the old valve that was there?
So the old valve gets compressed by the metal frame of the new valve, and then inside the metal frame is the brand new tissue that starts working.
That's crazy. So you just kind of push it aside. It's like,
it is.
You're worthless now. Well, we don't
it's
need
not
that
working.
anymore.
It's disease. We actually just move it out of the way, and it gets trapped between the wall of the vessel, pulmonary artery, or aorta, and the metal frame.
Okay. And after that, it just kind of gets all calcified. It just doesn't really. It's like you can't just go back and reuse it.
No. It's done. It's done.
Tell us what this is.
So this is the valve actually going in, and there you're seeing that the valve. This one is a balloon expandable valve, and so what happens is we expand the valve with the balloon under high pressure, and then you can see this valve was very leaky, so there was a lot of leakiness of that valve, and you can see there's no leakiness now.
Wow. And so that's contrast that you put in there to see how well it's working in position. The wire is sort of the frame for it, and the valve sits on the inside of that opens and closes.
Correct.
That's crazy.
Yeah, it's pretty amazing. It's this was not thought possible when this was first conceived.
So what are we seeing here?
So now this is the aortic valve. This is what Jack had. So now this is in the aorta, and that's the valve itself at the bottom, and that's the balloon that expands it. And to make it smaller and slenderize it, they go in separately. So then we have to load it in the balloon into the valve in the body, and once it's in the valve, it's ready to go. So our complete apparatus with the balloon and the valve are together in one unit. It goes over that guide wire, which is across the diseased aortic valve here.
Yeah, that looks like kind of a nasty looking valve.
Yeah, it's like, you see it's not really opening.
Yeah.
And then what you'll see here is that we'll get this positioned across that valve, and once we get it positioned there, we'll actually we'll have a temporary pacemaker in, and that temporary pacemaker will pace the heart at a very rapid rate to decrease the cardiac output so the valve does not move when we deploy it.
So actually going too fast instead of stopping the heart.
Correct, and that's how we reduce the cardiac output. And you can see this is the final positioning. And then we have an inflator that inflates the balloon under very high pressure, somewhere around 10 atmospheres of pressure. So if you're underwater 100 feet, that's 3 atmospheres. This is 10 atmospheres. And you can see how the balloon opens up and the metal frame moves those valve leaflets out of the way. And then you can see inside the valve are the leaflets. This is actually bovine tissue from the pericardium, or the lining around a cow's heart, that they manufacture a human-looking valve.
Wow.
And then everything comes out, and then we close up our entryway in the femoral artery in the groin, and people are walking typically 4 hours after the procedure, and most people go home the next day.
I remember people were on ventilators, on life support, multiple drips, all these drugs for days afterwards. And things work. Now, if this doesn't work, can you put another one in at some point? Yeah,
so these valves have a limited lifespan, about 10 to 15 years. So if the valve is not doing well, but our patient's still doing great, we actually go in the valve and put a valve in valve.
Oh, you put another valve inside that valve and just push that one down the way
exactly, correct. You know those Russian Christmas dolls?
Yeah.
You're putting a mama doll into the papa doll.
Okay, well, there you go. I'm not even sure I understand that, but I believe you. And what I'm hearing is that medicine is remarkable and that's amazing. How do you feel?
I feel great. I really do.
Oh, my God.
I feel fortunate.
Now, how did you learn your heart valve had to be replaced?
Well, I had an X-ray of my lung, and the technician who was reading it just mentioned that it looks like there may be some stenosis of the valve. And then my primary care physician, she saw that, and she said, well, let's get your heart looked at. So they did. KU looked at it, and sure enough, they said, you've got some buildup, calcium buildup, and there's a way to take care of it. And when I heard that it was a pretty easy situation to fix, from my view, I said, let's do it. And so I qualified. And
were you feeling short of breath when you had it?
Not too much, not too much, but it was gradual. Okay, it was very gradual, and I just was more lethargic. Didn't want to exercise. Didn't want to do much. So there were signs like that.
And once you get the new valve, you say,
immediate.
I'm feeling better.
Yeah, it was immediate. Yeah.
And that's pretty classic. So a lot of people, as they get older, they think, "Oh, I'm just getting older. I'm slowing down." And they don't. And aortic stenosis, develops very gradually. So people don't realize it. And then once they get the valve replaced, they realize, "Oh my gosh, I'm not really getting older. It's my valve, and now I can do so much more." So this is a very classic story that we hear.
So, Dr. Tedros, is there a way to catch this kind of thing early so you don't have to go to valve replacement or valve surgery even with TAVR?
So, I mean, eventually, unfortunately, there's no medical treatment for this. This has to be done with a replacement.
Okay.
And our replacement choices are really minimally invasive, TAVR or surgical replacement.
Well, this looks so much better than having the whole, let's open your chest, get the saw out, crack through your sternum and all that. But there's still patients who can't have this. Tell us a little bit about that.
Correct. So it depends on the cause of the aortic stenosis. There's also certain anatomic features that are not suitable for these valves. So when we decide to do that, we actually go through a battery of tests to look at their coronary arteries, make sure there's no significant blockages. To look at their anatomy, they go through a very sophisticated CAT scan that measures about 30 elements around their anatomy to see if the valve is suitable. So there are different types of valve, and they all come in different sizes. So we have to make sure that there's an appropriate type and size that would fit a patient.
Yeah.
And then there's a choice between, these are all tissue valves. There are mechanical valves that can last indefinitely. So if a patient is younger and they need a valve to last a lifetime, so 40 years, for instance, we don't want to be doing serial valve procedures or surgeries.
Yeah, because it would get a little smaller.
You can't keep putting you put the Papa doll, the Mama doll, the
And
little.
pretty soon you're
pretty
done.
soon you don't have enough room.
Yeah.
And so those patients need mechanical valves, which. And the reason we move away from that as we get older is that the mechanical valves require lifelong anticoagulation or blood thinners with warfarin and or Coumadin is the trade name. So in younger patients and patients who their anatomy is not suitable, we'll choose a surgical approach.
All right. So, Jack, after your procedure, how long before you were back home?
A long 30 hours.
Oh my God, that's so long. You were here like a little more than a day.
It's unbelievable, really.
Yeah, and you felt that much better right
Yeah,
away.
oh yeah.
Isn't that crazy?
It is
just
crazy. I call it miraculous, really.
Yeah.
I mean,
so,
really.
just to say, you wore a red shirt here today, which is so appropriate for talking about heart surgery. Was that planned?
Oh, definitely.
All right, well done.
No,
I
actually, my
appreciate
wife
that.
had it out. You know.
So, Dr. Tedros, there are a lot of heart valves on the market. Some are made for pork, some cows, some are mechanical, et cetera. You talked a little bit about which one, but how about the tissue thing? How do you decide between like a pork and a cow?
So it depends
By the
on.
way, I like beef better.
Okay, yeah. You like beef better?
I don't know, ribs are really good, especially
I know, it's hard.
Gates.
So again, it's not really the type of tissue. The tissue really in our minds are equal. It's really the design of those valves. So there's certain anatomies that fit these valves better. And so we'll look at what's the best fit based on the design of the valve. And that's how we choose them.
So if this is a standard of care, is this kind of something people do everywhere, or do you have to have a lot of experience?
It's definitely what they've shown is that, like with most things in medicine, the more experienced you are, the higher volume, the more likely the outcomes are going to be better.
Yeah.
So they're really usually specialized center, although this technology is now maturing, and we're on our 4th generation of these TAVR valves. So it is now spreading out into the community a lot, but I would say you definitely want an experienced team. It's not just the physicians, but the whole team. That's really important for the good outcomes.
Yeah, and you guys still have a surgeon and the cardiologist there together?
We do.
Yeah, is that in case something goes wrong? You have the surgeon right there?
The surgeons, you really actually need both sets of hands. So the surgeon actually participates equally in the case. The surgeon is also there should something go wrong, but that is really a rare issue these days.
Yeah.
So really it's more to get the procedure done, because really it needs 2 sets of physician hands to do it.
And the thing about if something goes wrong, if you select the right patient, I'm betting that doesn't happen.
Correct.
So
and
often.
patient selection is really critical.
Yeah.
Really critical. And that's why we do through all that testing prior to
That's just crazy.
Yeah.
Okay, we're going to be here to answer your questions. Send them in using the links on your screen, YouTube, Facebook, or email the Medical News Network. We're going to check in now with Doc Cox, who a few minutes ago I blamed for the current rise in COVID. That's probably not true. Well, maybe it is. Let's ask him. But now, because COVID is not staying quiet this summer, if we look at a CDC wastewater graph, you can see the steady upward climb with no peak in sight, and it's worse than last summer. I was looking at this data about a week ago, and it's starting to kind of go up at a higher pace. And I'll just say I'm having a lot of patients test positive, and honestly, when I came back from a fishing trip about 6 weeks ago, I was positive. But I never felt too sick this time around, Hawk. Do you think people are sick this time?
Yeah, I think there are those at-risk individuals, and I think it's those people with those chronic conditions, maybe cancer, getting chemotherapy, other immunocompromising conditions or treatments or drugs that they are taking that would make them immune compromised. But for the most part, the general population is probably not going to be as sick, and I think it's more of a combination of that infection and reinfection, but of course, most importantly, the vaccination and revaccination. vaccination. And if you fall under the criteria of needing to get a second dose or an updated vaccine dose, then please go get it. I know we are kind of running into that cusp now where the new vaccine will be out for the 2024-2025 respiratory viral season, that updated COVID vaccine. So I think the question is always, do we give it or wait? I think it's a conversation you need to have with your medical provider.
Yeah, and I know some of my sick folks have asked that very question of what to do or what to wait. You just have to do. You have to weigh those concerns, knowing that even if you get a vaccine now, you can still get another vaccine in 3 months. I mean, that's not a big deal, and I don't think.
Yeah, absolutely. I know that we have had multiple studies, multiple meta-analyses, multiple reviews showing the safety of these vaccines, but more important, the benefit as well. So, and of course, remember, if you do have it, and especially if you're high risk, trying to get on the oral antivirals is going to help reduce your chance of hospitalization.
So I think we've got the rise in test percentage, or maybe that already popped up and I missed it, but I know that there has been an increase in the test percentages that have been popping up in ED visits for COVID. Yeah,
we can look at that. And on the left side, you see the early indicators, test positivity. Again, all of this data, there are caveats just because there aren't as much or many institutions who are submitting data still, but this is the best information that we have. And just as you showed before in the wastewater, we see this uptick. If you go to the far right of that left-sided graph, test positivity is 12%. But more importantly, the emergency department visits. And this is percent of people who are actually diagnosed with COVID-19. And you can see there was that nadir there, but we have seen now an increase in the percent of positive people in the emergency department. The second one we'd like to show as well, so this is hospitalizations, and this is always what we think is more important because that means you are ill enough to go to the hospital, unfortunately. So what you can see now is the rate of hospitalization per 100,000 people is 2.5. I think this is different than approximately 6 or 7 months ago when we had a recent peak of 7.5 people per 100,000 people were hospitalized with COVID, but it is nowhere near the total peak that we had, which was in early January of 2022, which we had 35 per 100,000 people being hospitalized. That is a large number. We did reach a low and a nadir back on May 4th of just 1.1. I think what I would like to show also is that that right graph right there with deaths. This is total deaths, or total percentage of deaths in the nation. Right now, 0.9%. But I would like to just talk about the numbers. We don't have this graph, but it's kind of similar to what the deaths is showing on the right there. So on July 13th, the unconfirmed total deaths in the United States was 202 from COVID, but we should contrast that to the peak of 26,000 deaths in 1 week, and that was the week of January 9th, 2021. So overall, just as you said, Steve, we are doing better. I think it's a combination of that population and individual immunity owing to that.
Yeah, our death number there was like a 1% of what it was back in 2020 or 2021, but I do think it's something to keep an eye on. It feels like the combination of vaccination and people have had recurrent infection, not as severe this go around. But all that has to happen with this virus, or any virus really, is a small modification of it through its own variability and reproduction and replication process that it can become a much more concerning virus.
Yeah, and luckily what we have not seen through all of the variants is that fundamental change that you're talking about that affects our immune system in one way or the disease severity for the virus as well. So that is good news. I would like to just show a graph real quickly because we talk about wastewater. There are a few sites in the United States. Kansas has, I think, 5 sites where wastewater testing is done. There are 3 around this area, around Wyandotte and Johnson County. There was 1 there in Lawrence, and then there is 1 in Salina as well. So that's where the state of Kansas is getting their data from to ship it to the national data source as well.
Now let's talk a little bit about bird flu. It sounds like recent cases in Colorado were among farm workers who struggled with using PPE while in the middle of a heat wave. No surprise there. But a little more bird flu in some patients.
Yeah, so bird flu, again, it has been around really since 1998. It is this influenza virus that mainly infects poultry, other avian species, and then infecting humans. We have seen larger outbreaks within the past 20 years. Right now in the United States, we know that it is a huge deal because it affects not only our poultry and chicken farms, but also the dairy cows, the dairy farms. So we are seeing now a few cases of human disease. And overall, in 2024, there have been a total of 7 cases, 11 since 11.
I was say 11 in 2022, but 7 so far.
7 so far.
Yeah.
Of those, since 2022, 5 have been confirmed as H5N1, so we believe it's probably all H5N1. There have been 7 human cases following poultry exposure, and then the rest have been through the dairy cows. But what we have not seen really is any severe disease or anything of that nature. So I think that
it says a lot of 100 million poultry were affected, and some. So I think there are still concerns about there. I think something we have to keep an eye on around the bird flu. I'm probably a little more nervous about this COVID thing because it's just coming high, and as to your earlier point, immunocompromised, immunosuppressed patients still can have challenging outcomes from that.
Yeah, and what I would say is to one of your early points about the avian influenza, just the PPE was probably not being able to be worn properly due to the extreme heat conditions during the culling of those poultry flocks. We remember exposure a lot for this. I suspect is probably more related to the PPE practices rather than aerosolized catching of the virus due to it being in the air from the chickens. You know, you have hot, sweaty conditions. You're not able to wear a mask because you can't breathe because it's so hot. You're probably having contamination on your hands. You're rubbing your face, your eyes, your nose. I suspect that is probably the main factor which is contributing to these human cases most recently. So overall, it is not a large or significant danger to the general public. But it, again, just as you said with SARS-CoV-2, we have to watch for any of those changes that would make it possibly be a bigger threat to the human population.
We know many of you have questions. We're going to head now to Studio B with Alexis. Good morning, Alexis Del Cid. How the heck are you?
Good morning. Good to be back. And this is a really cool question because I don't know the answer to this one, but you might. Doctors, Gene Reardon wants to know, what kind of valve did Mick Jagger have?
Well, I got to tell you, I can't get no satisfaction without the answer to that question.
We know you have the moves like Mick Jagger.
That was a pretty good one right there. Come on, Mick Jagger, Rolling Stone. Okay, fine. The question is, what kind of valve did Mick Jagger have?
Yeah.
He had a very similar valve that Jack had.
All right,
yes.
Mick Jagger.
Okay.
Yeah.
Jack. There's anything about the J's here?
I still can't play the guitar.
Oh, well, okay, fine.
I hear you're a lot like Mick Jagger, though, Jack.
I do.
Yeah.
You just get better with age. Gene Reardon has a follow-up question. He wants to know, should you take, this is about vaccines, should I take a booster now or wait for the new vaccine? I haven't had a booster since December.
What do you think? Since not a booster since December, a little nervous.
Right.
And Hawkeye, I think we actually have our inpatient count. We haven't given that inpatient count in forever, but we know now.
We were able to get the information from one of my infection prevention colleagues, Lance Williamson. We have 7 inpatients now, so you know,
we were down to 0 and 2 for a long time. So 7's not a big number, but it's trended up a little, I think.
Yeah,
which is typical what we're seeing across the country.
Yeah, and hopefully we can keep those numbers low in that single digit or 0, just like you said. Yeah, I mean, I think that it is just a discussion with your primary doctor. It is not going to hurt. The other thing is, do you still have it available? I know a lot of clinics don't have it available. Unsure about the clinical pharmacies or the commercial pharmacies. But we know with increasing or rising numbers, it certainly wouldn't hurt you. Probably, it's hard to tell when the new vaccine will be out, maybe September, or later September, early October. But you can get the dose now. It's not going to hurt you. Obviously, it is a few variants separated from what we are dealing with now. It still could boost some of that immunity, but as far as really protecting against infection, probably will not be a high percentage of protecting you from infection from the new variant or variants that are circulating at this point in time. But we know that it will be safe and will not cause you any harm.
Jeremy Yenser has a question for Dr. Tadros. Jeremy writes, with a reduced recovery time and being less invasive, does this allow people to have heart procedures done that previously might have been too risky to have surgery?
Great question.
You have to tell me the question.
Okay, that's right. You're so here's the question.
Yeah.
In patients who may have been too at high risk for a heart surgical procedure, can they get this less invasive approach?
Oh, for sure. We have a lot of patients who are actually extreme risk or actually ineligible for open heart surgery who get this valve. So, so we have a lot of patients in their 80s and 90s who go through this procedure. Our oldest patient went through it was actually 102.
Holy cow!
Oh, wow.
She lived to 108 with the valve working well.
My goodness.
So, so yeah, so this is definitely so much easier for someone to go through than open heart surgery, even with modern techniques.
I just want to say, I'm still so impressed that you just kind of crushed the valve open. This brings new meaning to the word that I've got a crush on their heart. Okay.
Goodness.
Next, back to you, Alexis.
I like that. I like
Yeah,
that line.
it's not bad.
Yen
I did a Mick
Liang,
Jagger, I did a crush on your heart crush. That's pretty good.
you're poetic this morning.
No
Yen
worries,
Liang
Star Trek.
wants to know, can the old valve be removed without opening the chest? How can it be removed without opening the chest?
Which valve was that? The pulmonic valve?
He's not specific. He just wants to know, how can the old valve be removed without opening the chest?
So, yeah.
How can the old valve be removed without opening the chest? The answer is you don't remove the
You
old
do not
valve.
remove it at all. So
You just
so
leave
the
it
valve
in
is just
there,
moved
right?
out of the way by the new
Yeah.
valve. So those metal frames that you saw in those animations, they just move that valve out of the way, and it just traps it between the metal frame and the wall of the vessel.
And eventually it just kind of gets into what
it
we
gets-
call endothelialized.
correct.
This stuff kind of gets all
Correct.
over it, and it becomes a non.
It becomes part of the wall, essentially.
Yeah.
Right.
It is so darn amazing.
Yeah.
I have a question for Jack. Jack, I know you said you were home within 24 hours, but did you feel like you were back to 100% within 24 hours?
100%. I was probably 90%. I mean, just.
Well, and some of you
it didn't
said you
take
were even
much.
better because
Yeah.
your heart valves are working now.
I immediately felt better, really. So yeah. It was
That's incredible.
Pretty quick turnaround, really.
Stu wants to know if a replacement heart valve could interfere with the heart's electrical activity.
Okay, so Peter, the question is, can a replacement valve through the TAVR procedure interfere with the heart's electrical activity?
They can. The electrical system of the heart runs right by this valve. So even whether you have it surgically, replaced or with a transcatheter replacement, there's a risk for needing a permanent pacemaker. And that risk is a little higher. That's the one thing that the transcatheter valves are not quite as good as surgery. That risk is about 8% in the transcatheter valves, about 3 to 4% in the surgical valve replacement. So that's something we look for and are careful to observe. And again, there's a certain small percent of those patients end up needing a permanent pacemaker.
So forecast a little bit what's coming. What is Dr. McCoy from the original Enterprise or Star Trek show going to be doing in 2231 around heart valves?
Yeah, I can tell you, how about I tell you 2025?
Yeah.
So in 2024, we've had 2 new valves or 1 valve that has been approved for the tricuspid valve. So a valve replacement tricuspid valve. There's a tricuspid valve repair using a clip procedure that just got FDA approved a couple months ago. We're involved with 2 research trials for mitral valve replacement with 2 different mitral valve platforms. So really, and the pulmonic valve, there's new valves that just got approved a couple years ago. So really, we're treating almost all valvular disease with a transcatheter approach now. It's just, and it's exploding, and some of these are first generations, which are going to get better and better.
It's crazy.
It's crazy. So really, the future is going to be really minimally invasive, which is perfect because patients recover better,
so
they
much
feel better.
So when you say it's the future, but when are we going to be doing coronary bypass surgery like this?
Well, we're doing a lot with stents these days, so we can do a lot. There's still a role. There will always be a role for coronary bypass grafting, and there will always be a role for surgical valve replacement. So cardiac surgery is not going away. It's just, and what we're seeing is cardiac surgeons are getting involved in the minimally invasive, world as well. So there's a lot of really amazing things going on. Right.
That is just too darn remarkable. All right, this has been a great discussion. I'm really grateful to our guests, and especially you, sir, for being here today. I'd love to hear final thoughts. Jack?
I'm just happy, that I had the procedure done. It was really a good experience. It was really a good experience.
That's great.
Yeah.
Dr. Tadros?
Yeah, I just, this is really serious. So when you develop aortic stenosis, when it becomes severe, your mortality in 2 years is somewhere around 40 to 50%.
I remember that.
So it is really serious to get this. It's really a serious disease when it's present. And so it's really important to get evaluated by your primary care physician. We have so many patients that it's picked up, just like Jack, by the primary care physician. They hear a murmur, they get a CT like you had, discover it, and then they refer it on to cardiologists. But if you have any symptoms of shortness of breath, and there's concern about the valve, then your primary care doc can be a great segue to get us to the cardiology world and get it treated. And what we also see is that once the valve's replaced, your lifespan goes back to as if you never had aortic valve disease. So it is really life-changing.
That is crazy.
Yeah.
Doc Hawk, final thought?
I think it's amazing, with the advent of these mRNA vaccines in a rapid manner. We have these new heart valves that you don't have to have open surgery for. I think we need to continue to promote, endorse, and fund science and medical research, because these types of things, these health issues, affect all of us. And if we can help improve our quality of lives by doing this, we need to be doing that. So I certainly would always promote that funding and of the research and medical innovations as well. And then, of course, it is still tick and mosquito season out there. I know we've had some rain. Please dump out your standing water so we can reduce any amount of mosquito breeding or anything like that. We know mosquitoes can spread things like West Nile virus. Kansas Department of Health and Environment has put out the past 2 summers the high activity of West Nile virus around here, so protect yourself against tick bites and mosquito bites. Just understand when and where you're going out. If you're in the brush, if it's nighttime or daytime, there are mosquitoes that bite both in the daytime but also in the nighttime as well. So please wear your insect repellent as well and try to protect yourself from those infections as well.
All right, well, thank you. And thanks to our entire team of guests here today. This has been an outstanding program. I often like to talk about faith, hope, and science. And when you see the amazing changes that are coming to healthcare and to orphan disease, it's crazy and how fast it's changing. And to our point, Peter, you and I have both been here a very long time. Actually, I've been here longer. But I am so struck by the pace from where we were to where we are, and who knows where we're going to head. This is the golden age of medicine. All right, remember Faith, Hope, and Science. We're back next week.
Coming up Friday on the Morning Medical Update.
God gives you challenges. Stand up to them. That's all you can do.
When Randy Flanker stood up to a life or death diagnosis, a complete stranger also stood up. I'm Jessica Lovell on the next Morning Medical Update, a life-saving donation made from halfway around the world. Randy finally meets his new blood brother in person, Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.